In this video, we describe when and how to perform a laparoscopic bowel resection for colorectal endometriosis. In cases of multi-organ endometriosis, gynecologic surgeons must remain at the forefront of clinical decision-making and surgical care coordination. The technique presented is nerve-sparing, mesentery-sparing, and utilizes a nose approach where the anvil and specimens are transferred through natural orifices to avoid a mini laparotomy. Bowel endometriosis affects 8 to 12% of patients with endometriosis, and most commonly involves the rectosigmoid colon. Over 90% of colorectal lesions can be identified on a dedicated transvaginal ultrasound. Rectosigmoid nodules appear as a hypoechoic lesion that can be identified by following the hypoechoic muscularis layer of the anterior rectal wall. MRI may be used to further characterize the lesions and rule out more proximal implants. Imaging should describe size of the lesion, depth of infiltration, distance from the anal verge, and estimated degree of stenosis. When assessing depth of infiltration of a nodule, it is important to define which of the 4 bowel layers the lesion is infiltrating. Lesions superficial to the muscularis layer can be excised by rectal shaving. On the other hand, for deep lesions infiltrating the muscularis or more, a complete excision usually requires a full thickness removal of the bowel wall. This can be achieved with either a disc excision or a segmental resection. For deep lesions, disc excision is preferred when feasible given the lower risk of complication. Segmental resections are therefore usually reserved for the following indications. The surgical steps should be kept systematic and start with the mobilization of the posterior compartment, followed by the mesenteric dissection, resection of the diseased bowel segment, and the primary reanastomosis. Examination of the pelvis shows a normal-sized uterus along with a left endometrioma adherent to the left uterosacral ligament. Large endometriomas often obliterate the pouch of Douglas and must be drained and released to allow visualization of the posterior cul-de-sac. Ovaries can be pexied temporarily to the anterior abdominal wall using a suture on a straight needle to optimize exposure. A bilateral ureterolysis is necessary in order to prevent distal ureteric injury at the time of stapler applications. An attempt should be made at lateralizing the hypogastric nerve. When present, uterosacral ligament or parametrial lesions can be excised at this step. To define the borders of the rectum, the pararectal spaces are dissected on either side of the rectal wall. This allows to isolate the rectouterine fibrosis that most often lies in the midline. The rectal nodule can then be shaved from the posterior uterus, leaving disease on the bowel. The shaving is pursued until the healthy rectovaginal space is encountered. The segmental resection can now be performed. Here, we use a mesentery-sparing technique to avoid the unnecessary disruption of vascular and lymphatic supply to the rectosigmoid colon. The bowel mesentery is dissected off of the bowel wall, starting at the proximal edge of the lesion, and moving circumferentially until a fenestration is achieved posteriorly. The dissection is pursued caudally and ends when the distal edge of the lesion is reached. If needed, the sigmoid colon can be mobilized to avoid tension on the anastomosis. Two rectal enterotomies are performed next, as shown by the dotted lines. The first enterotomy is performed near the distal margin of the nodule for the insertion of the anvil. A second enterotomy is performed at the proximal margin of the nodule for the anvil's later placement. Through the distal enterotomy, the anvil is inserted inside the abdomen. The anvil is then passed through the proximal enterotomy and is secured to the healthy proximal bowel edge by piercing the sharp tip through the anterior rectal wall. The diseased segment of bowel is divided from the proximal colon using a linear stapler. The segment is then divided from the distal colon sharply, and the specimen is removed through the rectum. The distal healthy colon is closed with a linear stapler, and the small segment of diseased bowel is removed through a laparoscopic trocar. The circular stapler is inserted rectally and secured through the rectal stump. Any excess mesentery is trimmed off. The anvil tip is removed. The two ends of the circular stapler are secured, and the anastomosis is completed. Care must be taken to avoid any twists in the proximal bowel, as well as any tension on the anastomosis. The procedure ends with a rigid sigmoidoscopy to ensure a negative air leak test. Preoperatively, a bowel preparation is required for the nose technique. Postoperative care should follow the ERAS pathway for colorectal surgery. Planning a successful nose bowel resection relies on accurate preoperative imaging and a multidisciplinary surgical approach.